So thank you for talking with us today. I want to start with you. This has been a very chaotic couple of weeks, 3 weeks now. How are you holding up?
I have a wonderful team. Honestly, not that anybody wished this upon ourselves, but I have a wonderful team. We've been working hard. We prepare, we practice. That's not to say that that we could predict everything that was going to come our way, but I will say that practicing really does give ourselves at least a structure to think through these complex problems. That we've developed good working relationships across our departments has been invaluable. So while I'd be lying to you if I said I'm getting lots of sleep, the reality is we're really very fortunate. We've got a great team here. So.
Some of the steps that people are trying to take to help them social distance, I think they have some questions about. If they get Instacart or they get something delivered to their house, can they touch the package with their hand?
Yes.
Where does that stand?
Yes. So let's remember the facts. And the facts are that this virus is, we believe, to be transmitted by respiratory droplets. And so you've got to have that proximity with another person who's coughing or breathing or sneezing in such a way that those droplets would land on a surface that you would either touch or would land directly on your mouth or nose or lips. So if somebody were to come to your door and drop off a package of whatever, and they were to walk away, and you were to come upon that package, that would be safe.
It wouldn't live on the cardboard necessarily?
Well, surfaces we think of as sort of smooth surfaces, metal or plastic. So, it's always good before you eat to, wash your hands and so forth. But I wouldn't view those surfaces as high risk.
A lot of restaurants, as you know, are going to takeout or delivery only.
Mm-hmm.
And we've got drive-throughs. All of that, according to what you're seeing right now, safe at this point?
Yep, I think as long as we take appropriate precautions, that the people who are working on the side of the food service establishment are washing their hands, taking all the precautions that we work on with them, and that customers are doing the same. I do think that these are different times. We've got to be a little bit more attentive to these changes, but I think we can take appropriate precautions.
Play dates.
Those are tough. I get it. Kids want to do something. We are social beings by our nature. And at the same time, this is a time where we have to reevaluate those habits. I think the play date is a tough one. The one saving grace perhaps is that we believe this virus has spared kids for some reason that we don't totally understand, but we're not seeing the degree of illness in kids that we might expect with other respiratory illnesses. Influenza, for example, much more an issue for the younger crowd, but that's not to reassure the public. We have to look at whenever you have a play date, you're going to have adults interacting as well, and I think that's the number one risk. And quite frankly, though we haven't been testing kids in very high numbers, the belief is that kids may be carrying this and for whatever reason are not building that reaction, those symptoms that trigger the desire to want to test and think through the context and all of that. So I think play dates, while tempting, do currently still represent a risk.
Once you have it, from what I understand, there's a chance you can get it. There have been case examples where people have gotten it again. Is that risk low, though, once you've had it?
To be honest, I don't think we know. I think if we can borrow from knowledge that we have from other respiratory viruses, we don't think so. But the issue of mutation, the issue of milder reinfection, I think those are questions that have yet to be answered. I think the better part of caution would be that until this thing is over, we ought to be taking precautions the whole way along, because the last thing we want is for us to sort of kick this and then to have another surge. And we see that with influenza. We have different strains of influenza in a season, and probably 3 or 4 years ago we had 2 spikes of influenza. And so, again, to the extent that one can borrow from what we know about other respiratory viruses, I think we ought to be cautious. And so until we get through this thing, let's keep our guard up.
And social distancing, you're saying, is perhaps the most important thing that we can do, perhaps even more important than anything that can be done in the hospitals.
Yeah, I think once you're in the hospital, we'll take care of you. We'll provide supportive care, all of the things that we need, but prevention is really what we need here. I think prevention is good, A, so that we keep people out of the hospital, keep them sick, and B, because we know that certain individuals are going to be at higher risk. People who are older, people who have chronic medical illnesses through no fault of their own, if they were to become infected with this, are more likely to be hospitalized. And we want to retain that capacity in the hospital so that we can provide that care for them and help them get through this.
Speaking of hospitals, how many beds do we have in our community that can handle COVID patients, and what does the capacity look like right now?
You know, even under the best of circumstances, capacity is always a struggle. You know, we are always looking at bed management. We dedicate a whole lot of people to bed management in our hospitals. I can't give you the exact number. I don't know the exact number. I do know that there is some flexibility in that. So, you know, as you've heard, you know, hospitals can cancel elective cases. We have ways of creating additional capacity, you know, up to a point. If we threw our hands up and completely gave up on social distancing, there is no way any hospital in this country would be able to withstand the surge that would result as a result of that. So I think we need to do these community measures while the hospitals are planning and creating that capacity. You know, getting people who have influenza out of the hospital is step one. That'll take some time. You know, not that much time because the flu season is really on its tail end. Surgical patients, you know, other patients, and you know, another major area that hospitals struggle with is, you know, we have people who need post-hospital care, and we've got to make sure that the capacity for the post-hospital rehab, long-term care placement, and so forth, that we sort of loosen up that bottleneck too. So it's a whole chain of events that you know, we focus on the hospitals often, which makes sense, but that's really only a piece of the whole chain.
Is the county, with the local hospitals, building right now any facilities, ICU facilities outside of the general buildings that we've been so used to?
Mm-hmm. Well, I haven't been down Elmwood lately, but I understand that there is a facility that is being built outside of Strong Hospital right now. That, I believe, is intended to be a triage sort of center. I know Rochester Regional is working on that also. But that is not meant to supplement the ICU. You know, to have an ICU, you need some, you know, substantial amount of equipment, personnel, and so forth. You know, we want to nip it earlier than ICU capacity need. So we're looking at ways, even before the hospital, are we able to identify people in their homes who might be at low risk, whether they need testing or not, to provide them guidance either directly by phone, through telemedicine, through FaceTime, and what have you, so we can keep them in their homes, maintain that social distancing, and you know, prevent anything from escalating even from that point.
Speaking of escalation, you're saying ventilators should only be really needed in the more severe stages of this disease.
True.
Is there any worry that we don't have enough ventilators? Should there be a surge?
We have the ability locally, as all counties do, to tap into state and federal assets for ventilators. And so part of our job is to be looking ahead and to anticipate the demand and you know, manage the demand to the extent possible. But if we need to expand capacity, there are avenues for that, which does mean that, you know, if we're not prepared, we will run out of capacity. So the goal here is to be prepared, to plan ahead, identify those needs in advance, and work with our partners across the state to get them.
Of course, if there's a surge nationwide or statewide, it might place a burden on you to get those ventilators, because all these different communities will be calling on them.
Right, and that's why public health is about partnership and working across the states, across the borders,
Yep.
to figure out how we can prevent all of this from hitting anybody.
Are you recruiting doctors from retirement, trying to get more people, more manpower in right now?
I have to say, I've been very grateful for a lot of offers of support from doctors, from nurses, from social workers, you name it. You know, this community has come together to really identify a need and want to work together. You know, just yesterday we learned that Villa of Hope would be willing to help us manage some of our telephone demand. And, you know, great partner in that, because many of the questions are coming from people who have worries, you know, anxiety, you know, and mental health is so important, particularly for somebody who's going through quarantine and just this stressful time in general. So, you know, that community has been exceedingly great to work with.
Has the medical community been able to take those offers from retired nurses, perhaps medical students, and so are they able to bring them into the fold?
We have medical students downstairs right now who are entering data, making some phone calls. You know, we want to reserve, obviously, the work that we believe we do the best for us. You know, calling an individual who's just been exposed to this is not something that we would throw a volunteer into. But, you know, when it comes to calling, you know, people who are now going to need to be in quarantine, people who we identify as relatively low risk, who we're going to be sending educational material to and so forth, those are perfect instances where we can capitalize on retired nurses and doctors. I mean, nurses are educators. You know, I
Right.
can't think of a better group of people, more so than even doctors, who would be willing to call a person on the phone and check in with them.
Right, so we're going to see more people come back into the fold in those education roles, perhaps not necessarily in the clinical.
Right, right. I mean, public health is really about education.
Right.
It's really about having a message that we can deploy to the community in a way that's acceptable and understandable and reasonable. You know, I think nurses and others are great with that.
I know it's been tough to pin down. At this point, do we have a general idea of how many people have been tested in our community for COVID-19?
So in the health department, we know how many we have tested, and I can get that number for you. Both Rochester Regional Health and UR Medicine are also testing. We don't yet have a good system coordinating all of that.
Right.
Coming this Monday, the Center for Community Health and Prevention, who helps us with our influenza surveillance, we're going to try to have something in place to be able to measure the COVID surveillance. It's complicated because the data come in from various places, and even at the end of the day when we're trying to figure out how many new cases we have, it is a little bit of a coordination game right now to get information from Erie County Lab, from Regional Lab, from U of R labs. So that is the thing that is important, because at the end of the day I want to go back and say, what was the surveillance here?
Right.
What was the prevalence here? What was the fatality rate? What was, you know, all those statistics that we want in any epidemic. We're early enough right now that we don't have a lot of those things in place yet, but absolutely a priority.
And I'm guessing because of that, but I'll ask anyway, do we know the percentage of people who are testing positive of those who have been tested?
High right now, because we are identifying people who are at higher risk from a pre-test standpoint, and so that's good. You know, if our initial testing was low, that would cause us to question the criteria that we were using to test. So right now, it's relatively high because we're testing the right people.
Those who survive, which has been all the people so far, what type of symptoms have they gotten, not just in the early stages, but in the latter stages as well?
Variable, actually. You know, the initial stages, as you know, are fever, cough, shortness of breath. But, you know, people who are older or who have chronic medical conditions don't follow the recipe for illness. And so some of them will find themselves in an ICU setting with very severe respiratory symptoms requiring ventilatory support. Some of them will have cardiac issues because the pulmonary stress is enough to cause a cardiac event. You know, so it's highly variable when you look at it at the sort of the intensive care side of things. You know, there is no one path toward wellness here. I think that's where we rely on the hospitals to deploy the ICU level of care, which is looking at every organ system and trying to, you know, pull things back together.
One of the main ultimate problems that we've seen in Italy, it's a type of pneumonia, and you're going to have to help me out with this, but when it gets to that stage, how difficult does it become to treat, especially someone who's elderly?
All pneumonias are difficult to treat, particularly in older adults. You know, this is a viral pneumonia, so therefore there are no antibiotics. Right. And for this particular viral pneumonia, there is no antiviral. You know, for people with influenza pneumonia, you know, there are antiviral treatments that are specific to that virus, but we don't have that here. Okay. So we're deploying primarily supportive care, which is ventilatory support, helping them to breathe, paying attention to all the other consequences that will arise from having, you know, difficulty breathing, making sure that people don't develop a secondary infection. So people with a viral pneumonia are at risk for other types of bacterial infections, bacterial pneumonia on top of that. So you could have two different pneumonias at play, which, as you can imagine, is a serious threat to the, you know, the lungs and so forth. But there is, again, there's no one path, and you know, medicine at that level is very complicated.
My last question, I'm going to have you walk me through your best case scenario and your worst case scenario.
Oh gosh. Well, I think the best case scenario, if you assume that, you know, COVID-19 is here, that the vast majority of us will come into contact with it, potentially become symptomatic with it. The best case scenario is that we identify that we recognize that the vast majority of people who contract this infection will have little to mild symptoms. That group of people can accept that, much as we do with influenza or the common cold, although those are very different things, but that we can accept that there's going to be some level of community infection that can be managed. that we don't enter this panic situation from those individuals, because what we really want to pay attention to are the people who are at risk for serious illness. So my worst case scenario is that whatever we do around the healthy and the relatively well, my worst fear is that that distracts us, depletes the resources, otherwise prevents people who are at most risk from getting the care that they need and deserve. And those tend to be older individuals who are, by definition, going to have more challenges accessing health care because of all the complexities that go around, being older with a medical condition. So I think as a community, we need to think very heavily about how do we help the people who are most at risk. And that's the perspective that I think is still hard, that's still evolving in this community.
So it sounds to me like what you're saying is there's a good chance that a lot of us are going to get exposed to this, but by employing social distancing, it will make sure that that infection rate is spread out over a period of
Yes.
time and allows for capacity in
Right.
hospitals.
Right, pacing ourselves, so to speak.
Got it.
So if you're looking at a team of people in a particular setting, a workplace, or it's, that not everybody gets sick all at once,
Got it.
that we take our turn, so to speak. And in that way, teams, families, groups can continue to function and not have to manage everybody being out all at once. When you look at the community, that's the same idea. We don't want everybody out all at once. We want to be able to anticipate so that we can have all of our resources deployed more over time and retain them again for the people who need them the most.
That makes a lot of sense. I did think when I was watching the news conference with you on Saturday before the announcement with Arcadia,
Mm-hmm.
you had gotten up to the podium and you said there are consequences to closing school.
Mm-hmm.
On parents, there are going to be
Yeah.
serious ramifications in our society because of this. And then Greece Central schools closed down, and then all schools closed down. I have to admit, there was a part of me wondering if you were perhaps on the fence about whether to do that.
I wouldn't be doing my job if I wasn't thinking about what the fence looked like. Because in all of these decisions, it's not simple. There are unintended consequences to literally everything we would consider. And I understand the desire to want to have an answer. I get that. We want to have structure, simplicity. That's, from a cognitive standpoint, much more comforting. But these are uncomfortable times. And when you think through the notion of a school closure, this is foreign territory. And while it seems tempting to say, well, lock down the schools, if the answer to that, if the solution to that is that everybody goes home and grandma and grandpa come over and provide daycare, we might not be solving the problem. So thinking through those dimensions, I think people do that in time. But when we're thinking with emotion and anger and reacting and so forth, we don't allow ourselves to think through those steps in a thoughtful way. And I think when we're navigating these uncertain times, it's not that we have the luxury of time, because we want to be decisive, but at the same time, we have to be thoughtful. We've got to pause a little bit and ask ourselves, what are the consequences of everything we're about to undertake? And I think that's the conversation that I want to encourage people to have.
So do you think that conversation will be had moving forward as we decide whether to open school up again?
Absolutely. As we look at the decision of when to reopen schools, we're going to be looking at the community prevalence. We're going to be looking at all sorts of data that we're going to have to develop. But again, I don't want to just open the doors and let the kids run in, because the parents need to think through what are the consequences of all of that, what are the arrangements that they've had, what's the reentry plan for both school and for work and so forth. That will require a conversation. So we're meeting regularly with the superintendent's group. I've known a lot of them sort of in passing and so forth, but I've gotten to know them as a group lately.
Right.
And they're a thoughtful group, and they understand that there is no one answer to a lot of this. And so I look forward to having that conversation with them in the weeks